Full disclosure, I am from Altoona, Pennsylvania, but I talk like I'm from New York. So people who prefer a different cadence, drink more coffee. Okay, so we're going to sort of hit on some stuff, and fantastic in terms of sort of Garth comment. I love when we're talking about things, and it turns out that we never met each other, but we're kind of on the same page. That says to me that's triangulation of data, so we must be accurate. But what I'm going to talk about and shift a little bit is talking about sort of good intention. You know, good intention's lovely, but we need intentional action in terms of addressing some elements. So there will be some issues that are similar in terms of issues about poverty and unhealthy space, but perhaps sort of more in terms of sort of what are some of the things lurking in the background, which may hopefully be sort of new news. All right, so I have no conflict of interest. I did this because this looked like glandular tissue, by the way. Okay. Here we go. All right, so good intention, intentional action, and underfunded mandates. What will it take? Pro-health arguments for mom and baby, accurately identifying highest risk, the hidden barriers to just do it, a sociologic framed approach, medical education opportunities, and getting granular with clinicians. All right, so everybody knows the phrase, the road to hell is paved with, right? Good intentions, right? And so good intentions are not necessarily what we need. We need sort of intentional, illuminated action, and I'll tell you what I mean by that. And we need to sort of pay attention to what is it that we say that are there, and there are some wonderful issues in terms of legislation, but is it funded sufficiently to actually achieve our implementation goals? And if not, what do we need to do to sort of go there? All right, so I have a phrase that I say a lot, okay? And I come from Philadelphia, land of sort of tasty cake and cheesesteaks, right? When the easy choice is the healthy choice, we've arrived, okay? Sort of the choppuccino salad that's really healthy, $10, cheesesteak, $2, right? So what's the easy choice? Well, obviously it's gonna be the cheesesteak, right? And so how do we switch it so we make the easy choice be the healthy choice, right? As a general internist, I spend a lot of time sort of helping people start with the very familiar unhealthy and help them migrate to the unfamiliar healthy, right, which isn't their space. And certainly in terms when we're talking about adopting breastfeeding when you're the first one, right, that's the same thing. We're going from the familiar unhealthy to the unfamiliar healthy, right? And how do we make that sort of the easy choice? So the pro-health arguments, and again, well illuminated both in your journal and other places, and again, I mentioned this morning, I feel like I'm bringing coals to Newcastle, y'all know this. All right, but in the short term, this is sort of the pitch. Oh, yay, faster shrinking of postpartum uterus, yes. Less postnatal bleeding, that's a good thing. Increased post-baby weight loss, also yay, okay. But longer term and less, you know, sort of well-defined, sort of more nebulous in terms of everything going on in lots of women's lives, obesity, diabetes, and sort of cancer prevention. For infants, for babies, we have sort of the acute stuff, late onset sepsis preterm infants in terms of lower rates, SIDS, necrotizing enterocolitis. We also have usual sort of illnesses in terms of otitis media, diarrheal illnesses, respiratory infections. That second cohort is, do you really want to be in the emergency room at 2 o'clock or 3 o'clock in the morning with your child having one of these? And potentially if breastfeeding makes that not happen, wouldn't that be better, right? And the long term in terms of diabetes, cancers, and childhood sort of obesity sort of issues. So highest risk, and again, you've seen this, so I'm going to go quickly, but I do believe in terms of poverty imposed, and I will agree with you that although Garth's moms is not inaccurate, there will always be those who have not amongst us. But I will take issue in terms of I don't think that horribly, abysmally, devastatingly poor needs to sort of be an acceptable stance for which we're taking. And we've gone from sort of have and have-nots to desperate, destitute, developing country worlds. I know in terms of North Philadelphia. You know, when I did the ELAM program, we had sort of colleagues that were from the United States, one from Canada. And on the last week that we were together, one of our colleagues, who was a trauma surgeon, so she rented the car, took us and showed sort of our different schools that we came from. And as we went to North Philadelphia, the pediatric endocrinologist from Ottawa who was with us looked out the window, looked at the boarded shops, looked at the litter, looked at the homeless, and she started to cry. And she said, how can you choose to do this to your own people? This doesn't make any sense. You have so much money, and yet you choose to let this happen. And, it struck all of us in terms of, yeah, you're right, so far as sort of the collective responsibility. So I take issue that the devastating issues of poverty, the devastating concentration in terms of communities in poverty needs to be something in terms of that we attend to. So if we look in terms of breastfeeding demographics, 6 times above poverty level, all the way below poverty level, and it doesn't go like 6 times below because that number would also go away, as well as issues in terms of lived life of sort of race. We sort of see some of the differences. We also know that teenagers, as well as sort of groups that we mentioned, are sort of at highest risk. Other ways, you would like to be the sort of purpley blue there. We have lots of folks who are not in terms of sort of issues. And again, mothers below poverty line, 19 percentage points less likely to breastfeed than mothers 350% above it. So the hidden burdens that preclude just do it, just breastfeed, right? And we're going to sort of cover these pretty sort of quickly just to go through. And again, I think many of you probably are aware, but the one I want to sort of start with, here we go, oops, are issues associated with trauma. So trauma can and often plays a role in individuals' lives. And from my perspective, trauma is sort of like that thing in your computer that somehow you downloaded and is playing in the background. And I don't mean that you're like spammed from abroad and that they're doing things for infiltrating sort of corporate espionage. I'm just talking about you open some stupid application that you can't figure out how to shut down and is playing in the background, and your computer's going slower and slower and slower. And so I think that in my mind, one of those things in the background that we're not really sort of paying attention to that we need to are issues about trauma. The trigger, the dose, the time it happens all vary. The history of trauma from a neurocognitive perspective, if we have sort of like I couldn't get the taxi cab, I'm bummed out, sort of frustrated, there's sort of a little arc reflex of dealing with that frustration that I go through. There's sort of like a happy moment where something good happens and I have a little dopamine squirt, right? But if I have sort of trauma that happens, it becomes sort of this like rat's nest sort of like entanglement. And so the next bad thing that happens, the next taxi that bypasses me that I can't get, really makes me melt down. Because instead of just like, you deal, they're goofballs, I'll get the next one, right? That resilience, it becomes triggering of other losses, of other bad things, of other stuff that happened. And in truth, this is not an insignificant thing in the lives of women. So history of trauma leaves a tangled web in brain processing, affects thinking, emotion, and decision-making. We know that in newborns, if you look at their brains at the beginning, it's lots of white space, and very quickly, all the nerves start developing, and it's just like, goes like this. Unless that infant is living in a traumatized household, and because of fight or flight and because of cortisol, it shuts down all those nerves growing, especially in frontal lobe, later in terms of executive functioning. And so trauma is neuroinhibitory in terms of individuals. One of my colleagues, Sandy Bloom, has done lots of work in this in terms of sanctuary. The basis of much of this is the Adverse Childhood Experiences Study. Raise of hands, people who've heard this. All right, we're all there. Okay, so I thought what was interesting for those of you who haven't, this is basically talking about, they looked at about 17,000, and again, think about sort of the people at risk that I'm talking about. So this is, in contrast, this is 17,000 San Diegans, mostly white, mostly college educated, and they looked for episodes in terms of various types of trauma. And they looked at them, and what they found is that the more issues of trauma, first they were very surprised. Most people had 2 or 3 categories. When you had 4 or more, you had a higher incidence in terms of unwanted pregnancy, smoking, death from heart attack, et cetera. And again, in this college-educated white San Diegan community, lots of work in terms of looking at other communities for which it will not surprise us, have higher rates have been going on. And the reality of it is this is saying something bad happened during childhood. As an internist, when I screen for childhood stuff, measles, bumps, broken bones, we do not routinely have anything bad, nasty ever happen to you. Anybody incarcerated, anybody with mental illness, right? We don't have that as routine in terms of primary care. Pediatricians are better. But in terms of most primary care, that's not a thing, and it should be. So Sandy's model is actually called Sanctuary, and it talks about self. Traumatized people may never have felt safe in their lives, ever, be able to identify emotions, feel that any change, even for the better, remember the familiar, unhealthy to the unfamiliar, that's a change. That's a loss that's just one too many. A belief that they don't believe that there is a better or positive future. And helping traumatized women means figuring out how to help them help themselves. Help them help themselves, right? Instead of what happened to you, or we say what happened to you rather than what's wrong with you. So the other thing that Sandy talks about is that people who are traumatized live on the triangle, right? Something bad happened, they were a victim, there's rescuing perpetrator. The rule of the triangle is once you get on the triangle, you have to play every role. So I, as a clinician, if I mistakenly don't know about this and you're having a hard time and you say, help me, and I say, yes, that's why I went to medical school, I'm going to help you, I'm going to be the rescuer, right? But I'm going to rescue over perhaps a victimization that happened decades ago. I can't travel back to when that person was 9 years old and a bad thing happened. So guess what? I'm going to fail. And as I fail, they're going to get ticked off at me because I failed, because I promised to rescue them, and I blew it. So what are they going to do? They're going to perpetrate because they're pissed. So they're going to perpetrate, and what am I now? I'm the victim, okay? And so as we go to help them, fix them, do for them, we jump on the triangle, and we have to play every role. Right? And so the stance is, when someone is sort of struggling, how do we help them help themselves rather than sort of that rescue? And that stance is really important in terms of one that's healthy. The other element I think important to realize is what Shafir and others have talked about, the cognitive bandwidth during poverty. So for example, right now as you're sitting here, hopefully, you're not worried about where you're going to sleep tonight, where you're going to get food, who's taking care of children. You're not worried about that right now, okay? There might be multitasking in terms of other obligations you have for which your phone is sort of saying, answer me, but you don't have those really core things sort of going on that your kids are going to be sort of left on the street and so on and so forth. We only have sort of a certain bandwidth, and if all those things are playing at the same time, when you go into the doctor's office and they give you really complicated sort of things to do, not a lot of it is going to stick. Sort of like how much of the water is going to go outside of that because there's just the overflow, right? And so paying attention in terms of the cognitive bandwidth that is constrained during poverty is really sort of important so that we can sort of have sort of what we say sort of land in a way that makes sense. Knowledge and perception of childhood development in a woman's body are also important. There are sort of many members in terms of the community who feel that babies are just little people. Right? So you see this young man right here, right? Right? And if this young man is attached to your breast, really, isn't that creepy? Right? Because he's like a little guy, right? So if I believe he's like a little man, that's kind of creepy. So I'm not going to go there. Right? And seriously, I've had pediatrician friends who've had newborn infants where the baby is just going like this, and the mom says, I think that baby just gave me the finger. And they're like, no, the baby's just moving his fingers. Okay? So understanding that babies aren't little people. In some communities, if you breastfeed, you're making them soft, and it's a tough world out there, so you can't make them soft, so you don't want to coddle him. And so how do we talk about sort of bonding and attachment as a separate thing in terms of intimacy to develop sort of a strong sort of man? There's fathers' attitudes of breastfeeding, as in, those are my breasts, not the baby's, right? And so if they belong to me, then they don't belong to the baby. And certainly, I believe sort of abstinent-only type initiatives that have eradicated sort of health education in public schools have really lost ground from sort of the level of our body ourselves date. So if we think about, what's a vagina? What is it and what does it do, right? And if a vagina is just to put in a penis or to put in a digit, and that's it, and not sort of menstruation in terms of health and heart and bone and things like that, and what are breasts for? And if it is just a sexualized form, well then breastfeeding's kind of not a cool thing, right? And so we have to, we have children, youth, at our pediatrics hospital, St. Christopher's Hospital for Children, and we ask the sexually active girls, are the boys wearing condoms? And she says, I don't know what he's doing down there. We talk about sort of back in the day, there were sort of mirrors to look at your cervix and what's your body part, and yet we've worked with incarcerated women who have no idea, 5 children later, how it all works in terms of giving birth. And so in terms of, sort of doing efforts to bring health education in the Philadelphia schools, maybe you get 4 weeks, maybe about something at health, probably not much in terms of sexual health. When we worked with domestic violence counselors about sexual health, these were bachelor's and master's level ladies, fabulous gals. But it turns out, as we were talking about sort of sexual health and asking about sort of sexual health screening for their clients, that they didn't know the order of the holes down under. bachelor's and master's level individuals. And so in terms of the need that we have for health education and sexual health, it's really powerful. Coping with feeling incompetent, how do you do this? How do you function with no sleep? If it's natural, how come it's not easy or it's not working? Remember I talked about sort of a traumatized person, one loss too many. Is this one loss too much? And do we need to sort of first help people helping themselves so that they can deal with sort of issues? Coping with competing demands. All right, so I'll tell you, I love browsers like Google, okay, because you learn so much. Google breastfeeding. You will find 300 pictures. 3 are African Americans. 1 is very, very light, but there's 3 of them, and there's a guy. Okay, he's not breastfeeding, but there's this picture, but the rest of them are all white. So if I look for social norms and I put in breastfeeding and I'm Hispanic, which I am, or if I'm African American, which I'm not going to see pictures. If I put pictures that say black woman breastfeeding, I'll find lots of folks from Africa. Now, there's no white indigenous ladies in those first 300 pictures. By the way, there's no like Victorian ladies who are breastfeeding or anything. So it's very interesting in terms of what are the messages about social norms. The other thing I learned in terms of Google is that apparently there are no women who have infants and toddlers at the same time, at least pictures of them. Because when you Google mom with sort of, children and so on and so forth, it turns out that anybody who is breastfeeding and has small children has one other child, only one, and she's usually kissing the forehead of the infant, okay? There are 2 other pictures where there's 2 toddlers who are delightful. They're sitting on the ground and playing and entertaining themselves or reading books, right? None of them are throwing cereal and running around like crazy, anything that resembles real life. It is important to recognize in terms of competing demands, we aren't octopus, we have limited arms. How do we sort of do that? I mentioned about social norms, what you see sort of on the internet, but and certainly the biggest predictor of teen pregnancy, of circumcision, of breastfeeding, if mom was teen and pregnant, if father is sort of circumcised, and if other people in your family have breastfed. So for some of our patients, have they ever seen breastfeeding, and do they have the resilience and support to be the trailblazer? In social pressures, think about when you got your coffee at Starbucks. Does that gal have a moment to take a break if she needs to in terms of breastfeeding? Really? Can she leak at work and not get sexualized by her partners or get snarky comments or feel mortified? And can she handle it if that happens? It's doing it all by itself. All right, we've certainly better scientifically speaking, sort of science must be fabulous. I love this. Came across this. We've learned from the breast. Okay, it's an ad for formula. If formula wasn't better, why would WIC provide it? Formula doesn't change based on what you eat. If you look at the ads with all these happy babies, isn't that what you want? Don't you deserve that? And if I eat poorly, it won't affect the baby, right? And so we have sort of forces sort of giving different messages out there. This is, okay. The other piece is that we know, for example, women living with HIV are often very good at taking their medicines because they're doing it while they're pregnant, and then when they stop, they also stop taking their medicines, right? So that deprivation for 9 months thing in terms of alcohol and all those other things, sort of being good in terms of pro-baby. Last night there was this Tales of Old Christine, I don't know, some sitcom I'd never seen before, and it was about pregnant ladies, interestingly enough. And the ladies were saying here's my glass of wine, so the moment I pop the baby, I can have my drink. Right? And so in terms of how do you sort of handle sort of that deprivation sort of post-delivery. System support and buy-in, the ability for negotiation skills, for co-parenting, for people that are raising the child, what skills do our patients sort of come to us with, and how do we need to help them, and how do we need to train everybody sort of who's involved. Convenience, this I thought was very interesting. This is a study amongst nutritionist students, undergrad nutrition majors, in terms of breastfeeding knowledge and attitudes. Convenience, nutrition, protection, economic, and father's relationship was sort of listed. But the message in there in terms of not only are there constraints that I have to deal with for convenience, but am I sort of a modern woman or not in terms of taking advantage? Garth mentioned in terms of having ways to sort of leverage solutions from community. One of our projects, the Philadelphia Ujima Collaborative Project, is a network of individuals and organizations working together to create a community of caring with the solutions coming from individuals, whether from church or school or organization, as we work together in terms of promoting wellness and support. And so being able to sort of leverage their interesting ideas so far as having voice and getting it right in terms of culturally and community appropriate is sort of very important to us at Drexel. In terms of getting granular for clinicians, I certainly recommend consider training clinicians to become trauma-informed versus trauma-reinforcing, learning skills to help women help themselves heal and stay off the trauma triangle. Imagine sort of how traumatizing to be told that you fail as a woman because you can't figure out sort of breastfeeding, and that just doesn't feel good for anybody, but if traumatized, it amps it up even more. I'm hiring culturally similar community aides, medical assistants, and training them in pediatric development, not little people. Frank discussion of over-sexualization of breasts, benefits of short and long-term breastfeeding for both mom and child, as well as motivational interviewing about some of the barriers that I mentioned. Starting the discussion with reproduction when it's not yet imminent, right? Preconceptual counseling, maybe with even renewal of contraceptions of somebody who wants to eventually have a baby one day. So it isn't just a, now we're going to do this. And reframing breastfeeding as part of a holistic reproductive scope, reclaiming sort of that a woman's body is not just a sexualized object, but really does lots of really amazing and wonderful things. From a medical education perspective, right now we're kind of on the eve of changing it up for medical schools. That's very exciting because where there is change, there is opportunity. Current medical education changes include using simulations, virtual simulations in terms of interviewing people on the phone, standardized patients, the flipped classroom, experiential and longitudinal learner exposures, team-based and interprofessional education, the community health education of group health sessions, using EMRs and patient education portals. It'll take a while. Eventually they'll get good. They're not there yet. Health apps and social media education. I'll mention two examples. We actually have had, and this has been for a long time, since probably about 1993, we had a wonderful protein biochemist who came to do a talk about nutrition and the nutrition in mother's milk, and the students fell asleep during the whole thing because it was biochemistry and it was boring. We collaborated with him when we brought in a nursing mom, right? And so in terms of sort of seeing this is sort of the real deal, this is why you have to do this, turned it to be one of the most popular lectures that we have and continue to have. A second example, and this comes from, we have sex and gender women's health scholars, so that students over 4 years can work on scholarly projects, do service leadership in the community, and create communication that is culturally and patient appropriate. We have sort of a new evaluated program called Moms and Baby Dragons, and this is a student health navigation for new moms. And so there's a curriculum they longitudinally follow with moms and sort of have these experiences in terms of doing that. So there are lots of opportunities to engage in terms of education about the benefits of breastfeeding. Are we identifying the right push or pull point, right? Can we pull out the right thing and not have it sort of all fall down? And I do think in terms of concentrated poverty, as well as sort of sick communities, that is an area that we need to sort of pull together so that we can sort of make a difference. So sort of from the ground up, from a sociologic sort of perspective, with the individual helping her help herself in terms of maybe a history of trauma, self-esteem, and healthier boundaries. Access and receipt of quality of education, both women's health, pediatric development, life skills, and a longer lead time. My big idea coming down here was maybe we need lacta-laquishas, right? We have Resusci Annies for CPR, right? So we train people how to do CPR, right, which is life-saving. Well, maybe we need a lacta-laquisha, right? So we can teach them, like, what do you mean by sort of latching, and what do you mean by, like, and how does that work, and so on and so forth, because if it's cool and fun, then, hey, I want to do this, and if I go to do it, I've played with lacta-laquisha, and so I can sort of try it out before it's sort of the real deal. Relationship and negotiation skills, and certainly sexual health, important for her, for partner, family, and social support, economic support, authorization for 2 pumps, one at work and one here, physical and individual support, education of the entire village, caring for children, not just the mother, and what if there isn't the village, what do we do? Trauma-informed organizations going through the training process, culturally and community congruous in terms of having community-similar educators and aides, online support councils, on phone with free minutes, sort of an avatar coach. Beyonce endorsing breastfeeding, which is very cool. Here's her picture. Now, you don't see her actually breastfeeding, but she endorses it, right? But sort of getting it out there. Celebrity men, right? We listen in terms of sort of Twitter feeds that celebrities do, which make it be a thing, and so getting them on board. When BET actually took on HIV, there were significantly increased upticks in terms of people getting tested for HIV, and they were very real of like, this is what I'm going to do and get tested. And it's like, oh, you're a good guy. You don't need to do this. Yeah, I do, right? And they sort of had that conversation. Well, whether it's Nunez, Oprah's, BET, Bounce, wherever, getting it sort of out there in terms of the storyline so that people see this. Music videos with breastfeeding that isn't sort of sexualized. Black Breastfeeding Week is a wonderful example. And again, I told you about sort of looking at browsers and finding new images and putting them up there so they actually look like people and not sort of the same old, same old. The push point, maybe attitudes of resources, time to breastfeed. Imagine if we actually had women staying home for 3 months that had support to be able to sort of raise their children and have sort of a living wage. Maybe OSHA should have a requirement, like we have for defibrillators, on-site pump and stations around the workplace for if they have reproductive women who work there. Auditing stations for the stations, as well as flexible breaks, and more awareness and advocacy about break time for nursing mothers law that was sort of not paid attention much in terms of Obamacare. So in summary, breastfeeding helps the health of mothers and children. Trauma is a potent variable and something I think to consider and look in terms of what might be playing in the background, identifying barriers at every level and trying pilots for solution, advocating for change, as well as sort of the root cause so far as wealth disparity and poverty and the collective concentration in unhealthy communities, providing real-life experiences and training, increasing incorporation of practices that support breastfeeding, and change, little or small, certainly can make a difference. Questions?
Good morning. My name is Lorena Gonzalez. I work for Urban Strategies and evaluate a program called Latino Best Start, which focuses on breastfeeding practices and education specifically for the Latino community. I just would love to sit and have dinner with you because there's just so much stuff that we could. So I'll try to be brief, but I want to make a point and ask a question. We ran focus groups. We ran about 30 focus groups around the country, specifically in marginalized communities. And one of the things that emerged around trauma was the act of breastfeeding triggering sexual abuse. And how do we get through that? What are some strategies for so many of our women who have been in that situation? And the second, in those focus groups, what we found is so many young teen Latinos, including boys, look to their future as foreseeing their partner, their wife, breastfeeding. I interviewed this 6'4", 300-pound guy and said, 16 years old. And I asked him, why do you want your wife to breastfeed? At 16, he's already thinking about that. He says, look at me. Look how big and healthy I am. My tia did it. My mother did it. My hermanas did it. Everyone in his family had observed this practice and looks in the mirror and says, yeah, that's what I want my son to look like.
Great. Thank you so much for your wonderful comments. So let's drill back. There's actually, for those of you who haven't seen it on YouTube, click on The Girl Effect. It is a very powerful video, very short, but it talks about sort of girls in poverty. It'll just blow you away. It's really amazing. But when we talk about sort of triggering trauma and re-traumatizing, we have to sort of, first of all, actually start going with sort of boys and girls in terms of sort of getting people to sort of have healthier ways to deal with relationships and negotiate that is not sort of hitting and controlling and so on and so forth. And we have legacies in terms of individuals for which intimate partner violence and or sexual assault are sort of common day things that happen. I think so that's sort of number one. It is way more than I think we think about it because lots of folks, bad things happen to, and they just kind of keep on marching. I've done sort of focus group with women living with HIV and hearing, at 9 on the streets, at 11 pimped out by mom, at 13 sort of alcoholic, and now sort of becoming a health educator and going to community college. And I'm thinking, dear God, sort of to your fortitude, to be able to deal with all this adversity and kind of keep on cranking rather than just say, I'm not going to get out of bed. So there is a lot of violence that happens against women that is sort of viewed as either normalized or sort of just another day. We do know in terms of pregnancy that racks up, up rates in terms of intimate partner violence because of sort of the sense of control or loss of sense of control. We know in some studies that boys as early as 9 or 10 know about reproductive coercion. They don't know it in that term, but they know in terms of sort of being a stud and getting a girl pregnant, you take the condoms out, you put little holes in, and you have sex, and that way she gets pregnant. as early as 9. Okay, so we have sort of lots of work to do in terms of violence prevention from very early ages on. And certainly in terms of screening, so far as intimate partner violence, what traumas have happened to individuals and how do we sort of help them help themselves to heal. Recognizing that, for example, even if we've sort of helped them in terms of having some progress, that anticipating, and this breastfeeding thing, sort of the losing control, the breast becoming, and sort of having this, having this sort of this stimulation could be sort of confusing and could make you feel a certain kind of way. So we need to sort of screen, anticipate, sort of educate, and then actually go further earlier in terms of issues about sort of the normative aspects of violence. So it's complicated, and it would be beneficial in terms of having resources to do that. Mm-hmm. Exactly. And how confusing that is, right? It's like, I'm being a good mom, but I'm kind of getting turned on, so that's creeping me out, right? Because again, in terms of a traumatized and sexualized piece, if breasts are just a sex thing, and I get turned on, then that's creeping me out because I want to be a good mom, right? And but I think we have to have a conversation about this, that these things sort of happen to folks, and that there's, again, not what's wrong with you, but what happened to you in terms of sort of clarifying, and how do other women who've had sort of similar experiences that have sort of gone further in the journey in terms of healing said, yeah, that happened to me too. Let me tell you how I reframe it. Not in those words. Let me tell you how I sort of look at it, et cetera, et cetera. And I think we need sort of help in terms of helping others, and then others who've helped to sort of give the right messaging in terms of individuals. Thanks.
Hi, I'm Carla Shepard-Rubinger. I'm the Executive Director of ABM, and obviously have lots of questions stimulated by your talk. Two in particular. One is, given your important role as the Dean at Drexel, what kinds of things are you able to or wanting to implement in medical education to address this? I mean, literally in the curriculum for medical students. Mm-hmm. Part of that is because I think back to Dr. Lawrence's stories about how ABM got started in California with a handful of committed physicians who were bemoaning the fact that nothing is taught about breastfeeding in medical education. So has it changed, or how can we change it? And the other question is related to that. Your project in Philadelphia sounds fabulous and is clearly targeting to do so much. How do you insert breastfeeding in the context of so many other important priorities?
All right. So I have another hour,
That's
right? No,
all.
I'm kidding. Okay. So first I'll share with you, as Carla mentioned a few months ago, my dean invited me to be the Associate Dean for Diversity, Equity, and Inclusion across the whole organization, College of Medicine and Biomedical Graduate Studies, staff, faculty, students, administrators, the whole schlegeagle. It's a pretty big space. So the good news is there's lots of stuff potentially in terms of doing, and so it isn't just sort of curriculum. It's actually recruitment. It's about dealing with unconscious bias. There's lots of really cool stuff. We'll see how much more gray hair I have next year, but there's lots of good things to do. So I think that, let me just mention a couple things. Oftentimes, unfortunately, in terms of diversity initiatives, a sex and gender approach is not sort of married to it, which I think is a real big absence, because when we're talking about all the different sort of components of diversity, a sex and gender approach is included, and certainly for us at Drexel, it's going to be sort of in there in terms of how we move forward and how we look. We're having sort of more experiential learning. There's issues, initiatives like the Moms and Baby Dragon. There's opportunities for training. We have to sort of beg folks who are busy lactation counselors to sort of let medical students come there, and I feel badly because I know they're overburdened and have a lot of work to do, but they're really doing important things in terms of having opportunities to make it real and to participate as part of the team. So we're investigating about sort of experiential issues that sort of help with that. I will share with you, when we in the third and fourth years, we send students lots of different places, and it wasn't that long ago of sort of a clinical site that isn't ours but is a regional campus of sort of like, oh, you're breastfeeding, well, there's a bathroom over here you can go to, I guess, right? Or just schedule when you're going to stop seeing patients so you can breastfeed because you know the timing that well, right? And so raising sort of awareness in terms of having a dedicated place, not only they're supposed to legally, but they should, as well as raising awareness in terms of, and training sort of students of, don't wait until you're like ready to rupture, go way before you think you are and say, I need a timeout and I'll be right back. Sort of negotiating those things in the workplace. I gave you the example of the baristas in terms of taking a break, but our medical students, you're in a case and you're going to be like, time out, right? I mean, so we have to the same sort of skills training and from that perspective as well. How much has it changed? What's very interesting right now in all of these changes in medical education to be much more experiential. The good news is there's fewer hours of sort of the lecture thing, okay? That's the good news. So they're dialing back lots of hours, which is potentially good, but also potentially bad. Because if you say, now I want to do an experience about sort of breastfeeding, they're like, oh, we don't have any time in the curriculum, right? So we just have to sort of be more clever in terms of the experiences that we give individuals. We have with our scholars opportunity to sort of raise awareness and have people be scholars tracks in lots of different fields. And so, for example, in terms of the topic of lactation, there's multiple things that students could potentially do locally, nationally, policy-wise over their 4 years. And so I think the more opportunities we can sort of dream up, the more help people need, that you could have sort of a medical student for a while, crunching some data, looking at some issues, say something, right? Because there's potentially folks out there that's part of their medical education, or could be if they have sort of similar type experiences. So I think that there's lots of opportunities, but honestly, when people dial back in hours, often they cut out the things they don't think are very necessary, and guess where breastfeeding fits in, right? So we have to figure out, nobody's going to say protein biochemistry is not important because it's on boards, all right? So at the very least, latch on, pun intended, to protein biochemistry in terms of a breastfeeding opportunity, and then consider others. Hopefully that answered a few of those things. Thanks.
Good morning.
Good morning.
What an amazing morning, honestly. My name's Kayden Saluja, and I run the WIC program in Los Angeles in Orange County. We serve about 250,000 women, infants, and children every month. Based on some of the things I heard from Dr. Graham and then from you, Dr. Nunez, the intentional action, I mean, I can't think of a bigger group of people who are influencers than the women and men in this room. And I just wanted to alert you of two things. You brought in the WIC program, so I thought, okay, this is my avenue to walk in. Yes, we give formula, and half of our infants in this country are on the WIC program. The Institute of Medicine has a committee that is looking at the WIC food package. It is reviewing its essentially recommendations to be given to USDA. The clock is ticking for comments to go in. The 29th of June, which is like 2 weeks away, is pretty much the last opportunity when they will be meeting and really starting to draft their comments, which are due January something. So one of our fears is they'll get lost with, the change in whoever walks into the White House. But real important for this August group to really start thinking a little boldly, which is, of course, we give formula. We make it look like, why not? Some discussions in the WIC community have really gone to the point that it's not that we want to make it more difficult, but let's not make it so normative. So if we go with the norm that women and breastfeeding and babies go hand in hand, then let's not offer that formula in the first month. What if we just said, we're going to just have women breastfeed in the first month? We do know that, because of our fabulous marketing practices, which will support corporate interests before anything else, women get a free sample of formula, universally, no matter who they are. My daughter didn't ever sign up for anything. It arrived at her doorstep the week before she delivered her twin babies. 8 months, exclusively breastfeeding, never a problem. So my point is that there's enough free formula around. It doesn't have to come from the hospital. Fortunately, in LA, we have lots of baby-friendly hospitals. It's a month. Women walk in. Workers in WIC will tell you they do everything short of turning cartwheels. They come from the community. They know the mothers. We have peer counseling. We have everything. Our exclusive breastfeeding, which we measure at 2 months, 22%. Can't beat it. Cannot budge it. It is so hard because just give me one can. So the last time USDA did this was 10 years ago in 2009. Well, it hasn't been 10 years, but it will be by the time it happens. What they came up with is that the states had discretion to go with 1 can of formula. well, one can of formula is a slippery road, and before you knew it, most states were pretty much, okay, whatever. So here's a comment, Academy of Breastfeeding Medicine, you guys are very powerful. A comment from you to the Institute of Medicine before the end of this summit. You're the influencers. Let's make it happen. Thank you.
Great. Thanks.
Hi, I'm Arthur Edelman. My calling card is I'm the editor of the Breastfeeding Medicine. So I welcome everybody to pick up the free copies if you're not familiar with it. Originally from Brooklyn. I'm going to ask a heretical question. The more I hear the description of the problems within various communities, be Afro-American or Latino, the more I hear the model of the paradigm of the stress, trauma. One has to ask the question, is focusing down on breastfeeding, really, should that be a priority when we're talking about communities and families and individual mothers who are overwhelmed with so many other problems? To sell them the idea that the long-term benefits, when the easy way out is to take the formula and reduce their stress, their trauma, and make it easier to cope with other problems, may be a reality. The question, where do you put in the priority, the breastfeeding? I'm talking about somebody who is obviously is an advocate. Mm-hmm. I'm not sure where I would put this in the hierarchy.
Well, so the question is, we all have sort of a time where, you cut off the leg and you're going to bleed out. Is this the time that I tell you about you should be safer in your car and, whatever, right? Like, no, I'm going to sort of attend to your leg because you're sort of, bleeding out. And so I think that depending on sort of where we intervene gives us degrees of latitude in terms of opportunity. If we're talking about pediatrics, if we're talking in an OBGYN practice, in sort of the contemplative, maybe acting but not really doing it yet, so far as sort of potentially having a child, if you're talking in that space to incorporate sort of about identification of trauma and helping people help themselves, that may give us the latitude of time in terms of getting a woman so that whenever she's at the point of breastfeeding, that she's not going to sort of be re-traumatized if she's breastfeeding. But depends on where the individual is. If there is somebody for whom this isn't sort of a new thing and they're sort of on the cusp of sort of helping themselves get to a better place, then that intervention may be sort of concurrent with the time whenever they're breastfeeding to sort of give them the support or evaluate. So I think it's individual dependent. It is also sort of lifetime dependent. I think if we do the root cause in terms of, Camara Jones has a wonderful gardener's tale about sort of, poverty of, the lovely pink roses and the yucky pink, lovely red ones and the yucky pink ones, and how we keep sort of throwing the pink ones there, but the beautiful red ones we keep nurturing and cultivating, and we say, well, these are kind of crappy ones. And so, we're all gardeners. We have a responsibility. So the question is, where do we have the degrees of freedom? Where can we implement that we can have the most response? For some women, we may not. It's sort of in the moment, you're just getting them through, and they're going from one place to the other, depending on sort of how severe it is. But for others, I think there's variability. If we never think about it, just like sort of in terms of diagnosis, if you never think the diagnosis, you'll never diagnose it. If we never think about it in terms of playing a role, then we're never going to sort of intervene and think about ways that it can sort of be different. So I think that there's lots of opportunities where we can, the moment of, child, here's your infant, latch now kind of thing. Is that the time in terms of sort of doing trauma prevention? Maybe that's not the best time. But I think that sort of considering that in the continuum of, hey, breastfeeding's a thing, sometimes people get sort of a little weirded out about it because they think it's kind of creepy, like this little man sort of sucking on their breast. And that's not, let's talk about that. So I think that we intervene where we have the time to intervene because fundamentally we want to sort of attend to the root cause in the long term.
Thank you. My name is Jessa Letter. I'm with the Pan American Health Organization. We're the regional office for the World Health Organization right here in Washington. That was just a really great talk.
Oh, thank you.
I hear a lot of talks, and, you kind of perk me up. So thank you. That was really great. One comment, some questions. Well, Philadelphia not only has a chili cheesesteak or the Philly cheesesteak, they're about to institute a soda tax. Mm-hmm. And the money is going to go to early childhood education. Mm-hmm. So, it's a leader in that respect, mm-hmm. second one in the country. So I wanted to put that out there because, again, it can be a leader in a lot of things,
Philly,
but
yes.
This is huge, I think,
Yeah.
for those of us that work in prevention of childhood obesity.
Mm-hmm.
In the Caribbean, because my experience is all in Latin America and the Caribbean, many of the mothers are teens. They're not married, often living with the child's father. Mm-hmm. And the through our focus groups, the father sees a gift of formula as a way of showing his love, is a way of showing his paternity. So I was kind of curious if that's come up in terms of what you're seeing in the communities you work in. But beyond that, because the role of the father is so important, in terms of how you're doing, how do you better engage with the father so that, that person supports the mother? WIC. Right after college, I was an interpreter in a WIC clinic. And it was in an African-American area, but increasingly Hispanic. This is in East Palo Alto. And I was always thinking then, before I was a mother, before I studied nutrition, but even then I was thinking, why couldn't there be like a couple options? Diapers, formula, I don't know, along with the food package. I mean, the incentives, which have changed in WIC, and I think have helped to get more breastfeeding at WIC, but the different incentives that women will respond to. Anyway, I've always sort of thought, why don't we give them another good choice that has value, where they can choose? I mean, I totally believe women should choose. And I think my other question is, you've talked a lot about everything you're doing and the barriers. Can you do something in your hospital? Do you have longer maternity leave, for example, as an example? What are you doing about the gift bags that include the formula? Have you been able to sort of get Mead Johnson and the AAP, to stop giving those things out?
A little bit.
So anyway, those are
Yeah.
kind of, start local in a way. I mean, we started a breastfeeding policy at PAHO. We have one at WHO. When I was there the first time 25 years ago, I had to express in the bathroom. I mean, we've started sort of doing what we preach. How can we tell other countries to be doing that, but we're not doing it ourselves? So anyway, that's a different perspectives and questions, but thank you again for your talk.
Great, thank you. I'll mention a couple of things. There's certainly a lot of our health initiatives for UGMA, we sort of had, this is the healthiest choice. And we realized in terms of the constraint that we were actually looking at the best of the worst. So these weren't the best choices, but the best of the bad choices. We sort of would migrate people to sort of do better than sort of what they were currently doing. So one step away from sort of what they were currently doing to kind of migrate them to sort of better and better. So I think that sort of options is an important sort of component with that. There is actually, I came across one thing where there is a hip hop artist for whom, sorry, I don't know who he is, but he's somebody, he's a celebrity, and I suspect if I knew hip hop, I'd know him. But what's important about this fellow is actually there's all these pictures on Twitter and Snapchat and Instagram where he's cleaning the breast pump of his wife. Right? And so, we do need sort of like, what's the role of the guy? When I talked about social support, what's the guy's role, right? What does he do? If he's kind of out of the loop because the breastfeeding things just happen between he and baby, like, what does he do? Like, how does he contribute? So we need sort of visible role models of what does the guy do? How does the guy sort of burp the baby in terms of intimacy? Like, what's their role? And it's really important to recognize that in terms of some of the things that we're doing, we're teaching it for the first time. My colleague who's a pediatrician talks about sort of, seeing this little 18-monther with all the buttons sort of buttoned all funny, right? And she said, what's the deal? Like, why is, Jamal is all, she's like, he wouldn't dress himself. And she's like, well, he's not 2. You need to dress him. And she's like, why? When I was little, I had to dress myself. Right? No one did for her, and so she would repeat in terms of like, if no one read, if nobody did colors, if nobody so did this, we're teaching it for the first time. And so it's important to recognize that maybe that isn't how their sort of, father or male figure in their life function for them. This is sort of a new day, and they can sort of have, their biology not necessarily be the biography, in terms of sort of moving it forward. But sometimes we're teaching it anew as if for the first time. So I think that there's lots of options and lots of possibilities. Thanks.
Well, I have a question.
Oh, you do? Okay. I won't go away. All right.
Well, you've been teaching medical students and so forth. And many years ago, we started a curriculum after the first Surgeon General's workshop. And we found out that nothing moved until the question was on the exam. And now ACOG and AAP and family practice all have questions on their certifying exam. Do you have questions on your quizzes?
Yeah, well, I'll give you an interesting example. We have a reproductive options sort of workshop that we do with some of our problem-based learning students. And in the workshop, it's just to talk about sort of how silly we think of probability, like 51%, flip a coin. Okay, but it sounds like, ooh, 51%, that means it's going to happen, right? And so we sort of love our numbers. So we have these little vignettes that they're doing reproductive sort of counseling. The infant may have thalassemia, may have 51%, may have Downs, right? And they have to sort of do who's the doctor, who's the patient, and who's the observer, okay? And oftentimes we'll have 3 young men. And when we do that, the young men will be like, we can't do this. We're not a girl. And so we can't play the pregnant woman. And so we can't do the exercise. Of which I say, well, I hope that you don't have to have migraines, lupus, cancer, prostate cancer, and so on and so forth for you to be able to identify with your patient. And pregnancy is sort of a condition that you're going to experience. And so, deal, play. So then they have to sort of become sort of, what is this pregnant woman? I think more opportunities for our students to sort of be in that space, to understand that, coupled with and it's on the exam, is sort of a nice 1-2 punch in terms of getting people to say, oh, this is a real deal. This is something that I need to attend to. Thank you.
Thank you so
Thanks.
much.